Yes, sir. Sir, I'm sorry, I haven't reached my home yet, sir. Is it okay if I can? I'm still in my car. Can I do it from
Yeah, yeah, yeah.
just?
As long as we are able to hear you, no problem. You are
Okay,
able
sir. Yes, sir. Yes, sir.
but don't risk your life if you are driving and talking.
No, sir. No, sir. I have parked my car, sir.
Okay.
Good evening, sir. The topic for discussion is on AHA 2025 CPR and ECC guidelines, sir. So, to start with an introduction, the 2025 American Heart Association guidelines for cardiopulmonary resuscitation and emergency cardiovascular care represent a major update integrating adult, pediatric, and neonatal resuscitation, education science, systems of care, and ethics. So, a total of 760 recommendations were issued, and 223 are class 1, and 451 are class 2, and 76 were class 3. So only 1.4 are level A evidence, emphasizing the ongoing need for a robust resuscitation research. So to start with the ethics in the resuscitation, which is a new chapter included in 2025, the 2025 guidelines introduce a dedicated ethics chapter here, focusing on the moral frameworks, equity, and shared decision making in the CPR and ECC practice. So the key concepts here are principalism, beneficence, non-maleficence, autonomy, and justice. So the health professionals must actively address the inequities in social determinants of health. Shared decision making should be practiced and emphasizing the patient goals and values. Uh, Default is to initiate the CPR unless irreversible death or a directive to decline or risk to provider is seen. Institutions must support clinicians facing moral distress and also provide family presence policies. Organ donation discussions only after the end of life decisions are made independently. The systems of care topic focuses on the on an integrated system where from prevention to recovery, applying an unified chain of survival for all ages and settings. So the all ages includes the adult, pediatric, the in-hospital cardiac arrest, and the outside hospital cardiac arrest. So here the single unified chain of survival is prevention, recognition, CPR or defibrillation, advanced care, and recovery. Safety hurdles recommend to prevent in hospital cardiac arrest, and public access to naloxone is recommended similar to the AED access. And lay rescuer programs, mass media campaigns, mandatory CPR certification. Telecommunicators are hands-only CPR for adults and conventional CPR for children. On-scene resuscitation prioritized and avoid transportation with ongoing CPR. And eCPR systems is regionalization and inclusion criteria is emphasized. Organ donation and post-arrest recovery systems integrated into care models. In the topic of neonatal life support, there are approximately 10 to 20% of the newborns which require assistance at birth, and 2025 guidelines emphasize anticipation, preparation, and effective ventilation as priorities. The key recommendations here are deferred cord clamping for more than 60 seconds for term and preterm infants not requiring immediate resuscitation, which decreases mortality. And intact cord milking reasonable for non-vigorous infants who are more than 35 weeks old. And the ventilation, regarding the ventilation, the initial pressure is to be 20 to 30 centimeters of water at a rate of 30 to 60 per minute, and CPAP if needed. And a video laryngoscopy is useful, and a laryngeal mask may replace EDT if face mask fails. The pulse oximeter has to be placed early, and target oxygen titration is per the SpO2 table. And chest compressions on lower third of the sternum, which the compressors has to be switched for every 2 to 5 minutes. Regarding the pediatric basic life support, the pediatric cardiac arrest is usually secondary to the respiratory failure or shock, and early recognition and effective CPR remains vital here. So the key updates here are interruptions in CPR should be less than 10 seconds, and the compression technique, heel of the one hand or two thumb encircling, which is two finger method, is removed from here. And the FBAO, which is an alternative 5 back blows and plus 5 abdominal thrust in children, or a 5 back plus 5 chest thrust in infant. This is for the foreign body aspiration, and the high quality CPR and early defibrillation remain the cornerstones here. And they also reinforce the community and telecommunicator training. Regarding the adult basic life support, the early high quality CPR and prompt defibrillation remain the strongest predictors of survival in adult cardiac arrest. The major updates here are regarding the compression ventilation ratio 30 is to 2 before any advanced airway. And regarding ventilation, one breath for every 6 seconds, which is 10 per minute with a visible chest raise. And in case of any airway trauma, if jaw thrust fails, head tilt, shin lift is allowed. And the mechanical CPR devices are not for routine use and may be used when manual CPR is unsafe. And for a foreign body aspiration, 5 back blows with 5 abdominal thrust until expelled or unresponsive. And the defibrillator, regarding the defibrillator pads, they recommend the adjustment of the bra instead of not to do not remove from the patients. And regarding the obese patients, the standard CPR technique applies here. And in the pediatric advanced life support, they enhance the pharmacological timing, physiologic monitoring, and neuro prognostication after arrest. So here the key changes are going to be early epinephrine within less than 3 minutes for a non-shockable arrest. And it is over to more than 20 millimeters of mercury indicates a good CPR quality. And avoid using any cutoff alone for termination. So the target diastolic blood pressure should be more than 25 millimeters of mercury in infants and more than 30 millimeters of mercury in children. For the supraventricular tachycardia, procainamide, amiodarone, or sotalol if adenosine fails. And maintain a systolic blood pressure of more than 10 percentile post-arrest. And regarding the EEG, up to 72 hours for neuro prognosis and multimodal assessment is needed. Assess physical, cognitive, and emotional outcomes within 1 year post-arrest. In the adult advanced life support, it focuses on the advanced intravenous interventions post BLS, including airway, drug therapy, rhythm management, and post-arrest stabilization. The key 2025 recommendations here are regarding defibrillation. We need to use more than 200 joules for AF or flutter cardioversion. Here they recommend a high energy and a double sequential or a vector change defibrillation. The benefit is uncertain here, but IV is preferred over an IO for drug delivery. Epinephrine after failed defibrillation in shockable rhythms, and vasopressin alone or in combo, it has no benefit versus epinephrine. And a head-up CPR is usually not recommended. And termination of resuscitation is it applies universal BLS or ACLS rule. No ROSC, no shock, and not witnessed. Unstable white complex tachycardias has to be synchronized cardioversion, and persistent unstable bradycardia, temporary transvenous pacing is recommended. In the post cardiac arrest care, it emphasizes the hemodynamic optimization, temperature control, diagnostics, recovery care, and for the survivors and caregivers. So here the key updates are to maintain a map of more than 65 millimeters of mercury and avoid hypotension. Temperature control should be anywhere between 32 to 37 degrees Celsius for more than 36 hours if unresponsive post ROSC. And consider a CT head to pelvis and echocardiography post ROSC to identify the cause or injury, and coronary angiography before discharge for any suspected cardiac cause. And neuro prognostication for more than 72 hours if after ROSC or normothermia using EEG on biomarkers. Psychological support and emotional screening for survivors and caregivers pre-discharge has to be given.
So you have mentioned about the organ donation also in the beginning itself. So that also comes after the post phase. When the suspected brain toxemia and less chances of recovery, then we can go for the brainstem death testing and then decide on organ donation and counseling. Okay. You want to discuss the other topic now?
Yes, sir, shall I start, sir?